Hello, everyone. My name is Chase Sanders. If you don't know me, I am the clinical director here for our therapy program at the center. And have asked our county directors to present some information to you as SIPP teams um, this month, and maybe depending on when your SIPP's meeting, either in July or August, regarding a new protocol that we are investigating and considering the feasibility of implementing, as well as if it's just anything that would be beneficial to us. And that is called the care process model. And this comes out of the University of Utah. They have a Center for the Pediatric Integrated Post-Traumatic um, Stress Response, and or PIPS. And they have put together CPM, or the care process model, as a model specifically designed for working within child advocacy centers to screen kids that come in for FIs, for trauma exposure, potential trauma symptomology, as well as some safety issues and other potential concerns. We want to get some feedback from you, as with any new model or protocol that we might think about implementing. You get kind of one side from the trainers and the people who have developed the model, getting some feedback from people who are actually utilizing this model currently, but we also want to hear from you as our SIPIT partners, as obviously we want to work together and make sure that we're all on the same page with this. And so this is not anything that is a done deal yet, but definitely looking for some feedback from you with that. So I'll try to make this as brief as possible, and explain a little bit about CPM, why we would use it, or why we might want to use it, and also give you a little bit of a kind of a walkthrough of what that might look like. So CPM was created really with four goals in mind. And I will share with you one of those handouts, or the roadmap, as they call it, for CPM. We'll look at the assessment document itself here in just a second. But really, those four things that we're trying to do with the CPM assessment. And this is specifically for kids who have endorsed traumatic exposure, which is going to be the majority of kids that are coming in for forensic interviews. I think in their studies in CACs in Utah, they're seeing about 8 out of 10 kids that are screened are endorsing that they have had traumatic exposure. Um, we want to first address the trauma safety concerns. We want to make additional CPS reports if that's something that is indicated. We might have kids that are reporting things. This does happen at the FI. Typically, most of the time this is done, and I think we would for sure be doing this after the conclusion of the FI. But sometimes kids are reporting things that are different types of victimizations that they didn't talk about in the forensic interview for whatever reason. We know kids are very literal a lot of times, and so they can be kind of narrowly focused in those moments. So ensuring the child is safe, making sure that there's any potential referrals that need to be made, CPS or whatever. Another issue that we're trying to address is the issue of assessing suicide risk and providing a prevention response if needed. And we'll talk more about that in just a second. We also want to provide trauma education to the children and their caregivers, and emphasize to them the availability of evidence-based treatment, and help assist in connecting them with that. And also, we want to teach kids a skill or share a resource that can be helpful to those families if they're having significant trauma symptoms in the time period between when they have their forensic and when maybe they can get started into therapy. And so, in order to accomplish those goals, CPM all starts with a assessment, and it is a brief assessment that is done again after the forensic interview has been completed. CPM is for children who are aged 5 to 8, or 5 to 18 rather. Ages 5 through 10 is completed by a caregiver report. The assessment is completed by the caregiver, I should say. Ages 11 through 18, the assessment is going to be completed by the caregiver or by the child themselves. So I messed that up, but 5 to 10 caregiver, 11 through 18 is going to be the child themselves. And here is what the screen looks like. Um, share, stop that share to share this one. Um, hmm, well, let me go ahead and close that out because it is not pulling it up as it should. Try that again. Okay, yes, there we go. So this is the CPM PTS screening tool. It is a screening tool that there's the caregiver child version, but they are essentially the same. Just the wording is changed depending on who's going to be taking or completing that screening tool. There is a paper version of this. It is also can be done electronically, like on a tablet. It is a self-report, so it's not that the a worker is guiding the family through these questions. It is a self-report. The electronic versions can generate a report immediately that is provided to a worker that can assist in how we respond to that. The paper version has a second page that kind of walks us through um, any interventions, responses that may be needed. So you can see here that the first thing that the CPM is screening tool is assessing is for a traumatic experience. Trauma screenings always have a component of trauma history and then a component of trauma symptomology. So as you can see, one of the things that's a little bit different from a therapy trauma assessment and therapy trauma assessments, there's a long list of things that might have happened, things that are potentially traumatic. The child answers yes or no, or caregiver, depending on who that is. On this brief screening tool, there's simply a prompt about things that could be traumatic. The word trauma is not really used in that, but scary, upsetting things. Someone's hurt, could be something they saw. And then the question is, has something like that happened to you recently? Yes or no? If yes, describe. Has something like that happened to you in the past? Yes or no? In a few words, describe what happened. So that's the extent. I know that there's some concern, concerns have been raised regarding, we're asking these questions about trauma experiences at the same time of the forensic. So this, I think it's really important to emphasize there's nothing leading in this. This is happening after the forensic, and I know it is a little bit different, but at the same time, these are questions that we would be asking for kids when they come into therapy. And potentially that's, the next day, probably not, but maybe within a week, depending on the situation. So I think from my perspective, yes, there's some logistical differences, and I recognize that, but at the same time, this, as far as, um, this sort of influencing anything. If our forensics is done, we're not doing follow-ups. I don't really see necessarily that there would be any real difference in when these questions are asked, if it's 15 minutes after the fact versus 15 days after the fact. It is also very clearly um, stated that this is not part of the forensic process. This is a screening for potential needs. Just like in our therapy, we're not conducting continued forensics exams. We're screening for treatment needs. So if the child or the caregiver does answer yes, there's been a traumatic incident and they give an explanation, then there's a prompting for answering some questions about trauma symptoms. So this would be within the last month, rating from this never happens up to this is happening pretty much every day. This is, again, very similar to what we would ask in therapy. It's just an abbreviated list because they are focusing really on just a few clusters of symptoms that are potentially most problematic before a kid can get in the time between when a kid has an FI and when they can get into therapy. And then the 13th question is regarding suicidality. And as you can see, it's just this general phrasing of how often have you been bothered by thoughts that you'd be better off dead or thought of hurting yourself in some ways. So from not at all up to nearly every day. That is the extent of what the family is answering. And so this should not take very long. The information that I'm getting from the PIPS staff is that most CACs, when they do implement the care process model, find that this doesn't really add any time to the time that the family is at the CAC, because you can usually find a time, especially if you're doing that electronic administration, where there's the 5 to 10 minutes that it takes to fill this out. You can usually find that within the processes that are already being done. Um, and so that's all that they do. And then the worker follows up with the second page, and I'll walk you through that, the electronic version of that next. I did want to really emphasize what this can potentially do for us. So I know I've said a lot of this is similar to what we do in therapy. It's kind of abbreviated versions of the screenings that happen in therapy. Well, really, there's a few things that CPM helps to do. One is, first of all, we want to make sure kids are safe. So that screening of potential traumatic events, like if the kids tell us something else that's going on, maybe that they're not safe in some way than what we know about, that we can make appropriate intervention for that. With the suicidality screening, again, we want to make sure kids are safe. Do we have a lot of kids that are leaving FIs and attempting suicide? No. However, we do know that kids who present to forensic interviews often are going to have had some thoughts of suicide or self-harm. The PIPS research from working with Utah CACs has shown that about 40% of the kids that come in for FIs report that they answer something other than never to that question about being better off, having thoughts of being better off dead or wanting to hurt themselves. Um, and we also know from the research and response best practices with suicide right now that a lot of suicides happen in response to acute stressors. So, something is there's a lot of pain, there's a lot of stress in a particular short time frame. And we know that a forensic could potentially be a trigger for that, or disclosure in and of itself, because lots of things are happening after in the period between disclosure and the interviews and things like that. And so, what we're wanting to do is to make sure that kids are safe. And if they do report that they've had these thoughts, I know from a practical perspective, it's like, well, we don't know, then do we have to do anything with it? But we want to know if they're not safe, and we want to be able to get them help that they need. I think one important thing to note is that sometimes we equate a child saying they've had a thought about hurting themselves with we have to make a crisis call, and that's going to be hours of involvement. And that's not actually the case. The If a child answers yes to or that they have had those thoughts to some degree, there's a prompting further questioning with the Columbia Suicide Severity Rating Scale, which gives a very evidence-based risk assessment, and also gives recommendations about what needs to be done. And it's very rare that the recommendation is going to be, we've got to call crisis, or the kid's got to go to the ER. Someone had asked me, kind of about that, and I speculated that I would imagine that was somewhere around 5%, and went back and of those kids, of that 40%, do report yes, it's really only, I said probably 5% of kids that actually had resulted in crisis calls. And I actually was looking a little bit more in the information and found that it's actually 7%. So it's pretty close to that. So most kids, even most of those kids who have reported those thoughts, are not going to need that. They're going to need maybe a little bit of safety planning, counseling on access to lethal means. So we know firearms and medications are the big two when it comes to suicide. And so if we can limit a child's easy access to those, we can really do a lot to keep them safe. Or maybe it's just giving them some coping strategies and skills. The other things that we're doing besides keeping them safe, we're getting that trauma assessment information. And so that can be helpful for us for a number of reasons. Does a kid need therapy or not? Not every kid that has a traumatic experience has trauma symptoms or needs significant trauma therapy. And so we a lot of times now we'll say, well, this kid has had this happen. Let's get them in. Let's assess. Let's see what's going on. But with the CPM, if we have a kid that we have really no trauma symptoms being reported, maybe that's not a kid that needs to be referred to therapy right now, or at least trauma specific therapy. Um, on the other hand, if we have a kid that is reporting a lot of trauma symptoms, this gives us some evidence-based, objective information to make decisions about um, treatment, about ensuring that kids as a team that we're having discussions about are this kid had a really high score, are they getting the treatment that they need? Um, if we have, a lot of referrals that have come in, we've got a wait list situation. We don't like that, but it does happen sometimes. It helps us to triage because trauma is not objective and logical in the sense that, just we can't always just look at what happened and say this kid is going to need therapy before this kid. Um, I don't know if they have gotten into this with this study, but there's some similar protocols that have also can kind of tell us these are some markers of a kid that is, if they have to wait, they're going to be about the same. Maybe they might improve a little bit over time versus a kid that's going to get worse and worse and worse until they can get in for treatment. Uh, Another benefit to that trauma information is to help us give parents or caregivers information that is useful in helping them maybe be a little bit more bought into treatment or to see the need for treatment. We know that trauma symptoms are often hidden, especially internalizing symptoms, so thoughts and feelings and things like that. And kids are probably, if they've not disclosed abuse, they're probably not talking to their parents about how their abuse is making them feel. And so we know that caregivers are not, especially with older kids, are not always the best judges of how their kids are really doing. And so, we make a therapy referral and we say, hey, we got this therapy referral. I want to get y'all in for treatment. Well, I think she's probably doing okay. Or, well, let me ask and see if it's something that they want to do, which of course, very few kids ever want to do therapy. And so they'll, hey, do you want to do it? No. Okay. Yeah, they don't want to do it. Um, and so we can have a little bit of information here that shows them, hey, your kid has some severe trauma symptoms, is reporting some severe trauma symptoms, and maybe encourage them to participate in treatment. And then also we are giving them just some information or some quick interventions that they can utilize outside of or when they leave, when they go home before they're able to get into treatment. And we know from some of the engagement research that if we can give families something concrete, something that is helpful and beneficial to them, um, even before they start therapy, whether that's in a phone call or in a initial contact such as this, that they are much more likely to come in and also to continue services longer. So, with that being said, I will switch over to an case example. And so this is an example of an 11-year-old named Trevor. Of course, it's just a fictitious case, but you can see that his trauma screening over here. He's answered yes. CJ made me touch his stuff in the bathroom. You can see his trauma symptom ratings. And so we see, especially in these last questions, we have a lot of fours. This is happening most all the time. And he has endorsed that he has those thoughts of being better off dead or wanting to hurt himself more days than not. And so uh, follow through to see, show you kind of what this would look like on the electronic side. By the way, this is also integrated into our NCA track as well. And so we can import that data directly over there. This is the first thing that we would see if the child has completed an electronic version of this assessment. And we see, the reason for his visit, the reason for the FI. We're using the self-report, a case identifier. So we have just a really quick summary. So brief PTSD-RI score 27, which that's a high level of traumatic stress. We see the summary of his what he wrote for his recent traumatic exposure, and some general recommendations. Here we have within his trauma assessment of symptoms, the three subcategories or three symptom clusters that they're looking at: sleep, intrusiveness, hyperarousal, and then avoidance and negative mood. As you can see, he's doing fine with sleep, but if we look over here at avoidance and negative mood, he's a 20 out of 20. So again, we have this. He's endorsed more days than not. So we're going to need to follow the Columbia Suicide Severity Rating Scale. And so this is where that goes. So this mirrors what we see on the paper form. This is just on an electronic version. So safety. Here's what he has said has happened. So the question is the response about trauma consistent with the reason for visit? Is it a new disclosure about child abuse? Is it a new disclosure? It's not related to child abuse, or did they not say anything? Are there any other actions that need to be made? So if we have, the child has said some things that are outside of what we know about, then maybe we need to take an additional action, such as making a CPS report. But right now, we're going to say there's um, no actions are needed, no immediate safety concerns. We're assume everything is, everybody is safe. Overall, how does the family think they're doing? We're going to say they know that there are difficulties. Then we move over to the next page. So since he did endorse those potential suicide or self-harm thoughts, these are questions straight off the Columbia Suicide Severity Rating Scale. Have you ever wished you were dead or you could go to sleep and not wake up? Say yes. Okay, and we would describe. Have you ever actually thought about killing yourself? Yes, describe. Have you ever thought about how you might do this? So we're thinking about the means. Yes. Have you ever had any thoughts of acting on them? We're going to say no. Have you ever started to work out the details? No. Have you ever done it? No. So we're going to say he's having a lot of thoughts. He's thought how he might do that, but he has not actually planned to do that yet. So we see is at a moderate risk for suicide. So again, not a crisis call. We're going to educate, develop a safety plan, refer to mental health. We're already doing that, hopefully. So what are we going to do? Well, we're going to say encourage communication. We're going to develop a safety plan. We've referred to mental health, um, and um, and so other things like that. All right, and then with the symptoms, he's got high trauma symptoms. So what are we going to do? We're going to say we provide information, and we're going to recommend evidence-based treatment. So what is the primary decision that we're going to make? We're going to help them with accessing trauma-focused therapy. You can see there's options there. If they're already in therapy, we communicate them with that therapy, and or having them follow up with that. You see, we're also provided here with some handouts and some materials that we can give families that go along with that. Um, Now, so we're prioritizing this avoidance um, because it is the highest. So we're going to um, give them a skill. And there's some materials that go along with this, the things that we can help them with. So we're going to say parent-child communication, and maybe we decide to do behavioral activation. We get results from that. And this is not therapy. This is like a 5 minute thing. Here's something that you can try to do. And then what are we going to do for follow up? Um, so we'll say we're going to call them in the next 2 weeks. But then you can see some other options there. And then that's pretty much it. Then we just kind of breeze through that, but that's what it looks like. Again, just want a little bit of feedback from you, especially our MDT partners, how this would be administered again and be after the forensic interview. In most circumstances, we might be able to play with that a little bit as far as other times when that can be administered, but scheduling becomes difficult. One of the previous models that we had looked at and we're in talks with implementing had families come back 2 weeks later for a follow-up. And while that's good, we know that there's going to be a certain percentage of those families that are that come to the FI that are not going to come to the follow-up. Just like there's a certain percentage that are going to get referred to mental health therapy, but they're not going to actually follow through with mental health therapy. Yeah, that's pretty much it. Thank you for listening. And if you have any questions, please reach out. You can let your director know questions, comments, concerns. You can reach out to me directly. And let me know thoughts about that. And what I can do is when I get those concerns, I can take those to the consultant that I'm working with, and also can kind of work through other CACs that are actually implementing this. How have you handled this particular situation? What has been your experience? And as we maybe help think to develop a plan, if we decide to implement this, we'll hopefully be putting our VAs and therapists through training. We're tentatively trying to coordinate that for sometime in September. They're going to do a specific training for us because of our size, and also as they are starting to disseminate CPM across the nation. NCA, our accrediting organization, is pushing CPM right now. They are the PIP staff are really excited about the potential of having kind of a larger organization, especially like within the southern region, to roll this out and to kind of have that example for others, CACs within the state and region. So look forward to hearing from you. I think this has a lot that could be helpful for us. But obviously, with anything new, there are things that have to be worked through and concerns. So I want to hear those and hope to hear from you soon. Thanks.